All right, welcome to the HVS interview series. In this series, we'll connect with experts in our field to discuss fascinating topics and share valuable insights. Before we dive in, I'd like to remind you that HVS membership offers a host of exciting benefits and opportunities. Be sure to visit the website to learn more about how you can join and get involved. Speaking of getting involved, if you're a young professional doing any type of heart valve work, whether it be in academia or in the industry or in the clinic, be sure to check out the Young Professionals Network within the Heart Valve Society. It is a great opportunity for professional development in this niche environment of ours. We also hope that you'll join HVS at our upcoming annual meeting, April 15th to 18th in 2026 in Chicago, Illinois. Now, it's my pleasure to introduce our guest for today's interview. Dr. David Kalfa is a board-certified cardiothoracic surgeon specializing in congenital cardiac surgery with expertise in complex congenital heart reconstructions, minimally invasive techniques, and hybrid procedures. Currently, he serves as Chief Cardiovascular Surgery and Co-Director of the Heart Institute at Nicholas Children's Hospital and is a professor of surgery and pediatrics at Florida International University. Originally from France, Dr. Kalfa graduated with high distinction from Marseille University and earned his PhD in biotherapies with a focus on cardiovascular tissue engineering from Paris University. He completed advanced surgical training across leading international centers, including Marie Lannelongue Hospital in Paris and Laval University in Canada, before joining Columbia University Medical Center, where he held key academic and clinical leadership roles, including director of the Pediatric Heart Valve Center and surgical director of pediatric cardiac innovation programs. Dr. Kalfa is an internationally recognized surgeon scientist whose work focuses on tissue engineering and translational therapies for congenital heart disease. He has had major international collaborations and is the recipient of multiple NIH R01 grants. Notably, his group performed the first ever infant abdominal partial heart transplantation, demonstrating the potential for transplanted valves to grow with pediatric patients, an achievement that has helped redefine the potential future of valve replacement, which is what we will be discussing today. I am Dr. Dan Chaparro. I have a PhD in biomedical engineering, and this is Dr. Ishit Chauhan, who has a medical doctorate degree.
All right, so let's start off. Very nice to have you, Dr. Kalfa. We'll start off with a broad question. Can you tell us how the idea of partial heart transplantation was conceptualized and how did that come into being?
Yes, absolutely. So actually, the concept of partial heart transplantation is the concept of using a homograft, which is a valve coming from a donor, but it's a fresh valve, right? So it's a valve coming from someone who donates the heart, but the function of the heart is not good enough to use these heart for a full heart transplantation. But instead of wasting the tissues, we can actually use the valves who are actually fresh and alive to replace valves in other patients. The concept of using fresh homografts or fresh valve coming from donors is actually something that is not new because, in the past, in the 60s and the 70s, the techniques of cryopreservation of the homograft didn't exist at that time, right? So surgeons were actually using fresh homograft. The difference between the use of fresh homograft in the past and now the concept of partial heart transplantation is mainly based on two things. Number one, we always try to limit the cold ischemic time of the tissue to the maximum, right? To decrease the amount of damage made to the valve. That's the first thing. And then the second thing, the second difference is that, in the concept of partial heart transplantation or living allogenic valve implantation, that's the same thing. Then we also use immunosuppression, right? Because it's a fresh and living tissue and because it's living, there is a potential risk of rejection, and I guess we can discuss about that a little bit more later. But we made the choice of using, some degree of immunosuppressive therapy. So to go back to your question, the concept itself of using fresh homografts existed, a few decades ago, but it has transitioned to this concept of partial heart transplantation by limiting the cold ischemic time and the use of a limited amount of immunosuppression.
That's very interesting. So you mentioned that this idea has existed, already, and this is something that that we wanted to expand on. So could you tell us about how this idea compares to the traditional approaches, such as the Ross procedure or like homograft valve replacement?
Yes, absolutely. So that's the big question here, because nowadays, or until now, right, there was no optimal prosthesis to replace a valve in a child, right? Even actually in an adult, but that's even more true actually in a child. Why? Because you have obviously the mechanical valve and the tissue valve, right? The mechanical valve, they do not have growth potential, and then they they lead to the formation of clots. So we have to use blood thinners and coumadin to prevent the clots, right? And this is associated with a significant risk of mortality, actually. Patients and children who get a mechanical valve implanted, right, have a lower life expectancy compared to the general population. The other option is the use of bioprosthesis, right? So bioprosthesis coming from cows or pigs, these kind of prostheses degenerate with time. There is an SVD, or structural valve degeneration, that happens, right, with some thickening and some calcification of the leaflets which stop moving usually, and we say that in adults it stops functioning well 12 to 15 years later. In children, the rate of structural valve degeneration is actually faster. The younger the child is, the faster the degeneration is, right? And the smaller the valve is, the faster the degeneration is. Okay, so these are not great options in children as well. You mentioned, the potential use of homograft. So the homograft is, or actually, you're talking about cryopreserved homograft, which is basically, a valve coming from a donor, but which is cryopreserved, right? So the whole cryopreservation process actually kills the tissue, it kills the cells, so it's not a living structure anymore. It cannot grow anymore, right? And also it tends to degenerate and to lead to some SVD and structural valve degeneration as well, right? So that's not a great option either. And finally, you mentioned the Ross operation. The Ross operation is actually and still I would say, the gold standard for aortic valve replacement in children. Right. So for those who are not familiar with the concept of a Ross operation, what does it mean? It means that we take the pulmonary valve of the patient, right? We harvest the pulmonary valve that we call the autograft, and this autograft is then used to replace the aortic valve, and it's implanted in the aortic position. Okay, so to be able to do that, so the main advantage is that this autograft can actually grow because there's a tissue from the patient and that's a living tissue. Okay. And also that's the only technique which actually shows the same survival and same life expectancy after an aortic valve replacement, both in children and adults, if you compare that to the general population who had no aortic valve replacement. Okay, so the Ross operation is really, really an excellent technique, but you cannot do a Ross operation in everyone. Number one, you need to be trained actually as a surgeon, right? And it's a pretty demanding surgery. So not all the surgeons, not all the groups can offer that. So it's not like something which can be, widely adopted by the community because of that and offered to the patients at a very scale range, number one. Number two, to do a Ross operation, you need to have a pulmonary valve, right, to be able to use it to replace the aortic valve. There are some congenital malformations, such as the truncus arteriosus, where you don't have a pulmonary valve, so you cannot do a Ross. Then you have some patients who do have a pulmonary valve, but the pulmonary valve is not working well. It can be stenotic or it can be regurgitant, and then you cannot do the Ross operation. And then finally, you also have some patients who have a general contraindications to a ROS, such as a rheumatic heart valve disease, right? Because the pulmonary valve, even if it's not leaking, actually can degenerate with time because of the rheumatic heart valve disease. You also have some connective tissue disorder, right? Like the Marfan syndrome or other type of syndromes like that. Same reason, right? You're concerned about using the pulmonary valve for the patient who had this genetic syndrome and put it into the aortic position, right? So the Ross operation is an excellent option, right? And remain the gold standard for aortic valve replacement in children, but there are some patients who unfortunately cannot get access to that, or it's just impossible to do that. And then in this type of population, then when a repair of the valve are not possible, the partial heart transplantation or living valve transplantation is a fantastic option to offer.
Yeah, awesome. So you kind of already touched on a little bit of the operating learning curve that might necessitate doing these kinds of procedures.
Mhm.
But I just wanted to ask, in your opinion, before we get into the operating learning curve, in your opinion, would partial heart transplantation, could that become the gold standard of treating congenital heart defects that you're describing so far? Or do you think it's just in those niche cases where valve repair is not possible?
That's a great question, Daniel, I think that we don't have the answer to this question yet, right? There is a lot of unknown, right, and a lot of thing that needs to be fully understood, to be fully studied, both from a clinical standpoint and from more like a translational aspect of things. But let's put in the ideal position where this valve. So we know that this valve grow, okay, and we can talk more about that. We actually, did the first multi-center retrospective study on all the patients who had a partial heart transplantation in the United States. And so I can tell you that, among something like now close to 50 patients total, right, with a maximum follow-up of 4 years and a half, right, all these valves are growing well. The relationship between the diameter of the aortic annulus or the pulmonary annulus and the BSA of the patient, the body surface area, is completely linear. And the Z-score remains very stable. So there is a true growth of this valve. And that's a huge plus, right? That's the first time in the history of pediatric cardiac surgery and the care of congenital heart defect that surgeons are now able to offer a valve replacement that actually grows with the kid. So that's completely disruptive. And that is already a game changer in our specialty. There is one potential drawback, which is the use of immunosuppression, right? So we have to use a very low dose of immunosuppression. We actually start usually with 3 immunosuppressive therapy, and then by months 2 or 3, we end up with a half dose of tacrolimus only, right? So that would be the drawback of this technique. But to answer your question about whether or not this can become a gold standard, I think that we need to have long-term or mid-term studies showing about the actual benefits, right, for the patient, by comparing the potential benefits and the risks of being on a very low dose of immunosuppression versus going back to the standard, which is a cryopreserved homograft, which requires, 3 to 4 reoperations in a lifetime, right? We need to really study and understand the balance of the benefits and the risk of each option, right? But if we compare, for example, for ROS, I was saying that the ROS is a fantastic option because, it can grow on the left side, but still, once you do the ROS operation and then you use the pulmonary valve to replace the aortic valve, you still need to replace the pulmonary valve. And to do that, so far, we were still using a cryopreserved homograft. So these patients were still needing, an operation on the right side, right? So if you think about the only way to really completely avoid any type of reoperation with a growing valve, for the time being, only the partial heart transplantation is offering that. So it may be possible that it will become actually the gold standard once we demonstrate that the benefits are much, much, much higher than the risk of a low dose of tacrolimus.
That's very interesting, Dr. Kalfa. You mentioned that you're leading one of the multi-center studies with a follow-up of 4.5 years. Uh, could you first tell us a little bit about how these particular patients are selected? What has been like your exclusion criteria for these particular patients, and what is in your specific case, what is your pre-operative planning like? What do you look at in terms of tipping something in favor of, okay, this would be a good candidate for partial heart transplantation?
Okay, yeah, that's a very good point because this is what we deal with, every single day with the patients, right? We have basically a series of tools, right, at our disposal, and then we will try to choose the best option, right, from every patient, right? It's a case by case, selection, right? We've discussed in depth, during our multidisciplinary conferences about what is best for specific patients, and then we have very long discussion with the family, right? To really understand what is best for a specific patient and for the parents as well, right? So we need to do a lot of education. A consult like that, when we are talking about the different types of aortic valve replacement, can take sometimes up to 1.5 hours before the parents really understand the pros and cons of an aortic valve repair, of a homograft, of a mechanical valve, of ROS, or a partial heart transplantation. So for the multicentric study, there was no exclusion criteria, right? We just wanted to give to the community an idea of the landscape, of the current landscape of the use of partial heart transplantation in the United States and actually in the world, because at that time, there was no other patient done outside the United States. So there was no predefined exclusion criteria, right? At that time, 5 centers were doing a partial heart transplantation, and there was actually some variation, right, in terms of patient selection, right, between the different centers. So we didn't have any specific exclusion criteria for that. Nowadays, in my clinical practice, when do I think about a partial heart transplantation? It's first of all for patients where I cannot repair the valve, right? When there is an aortic valve or a pulmonary valve or a mitral valve or a tricuspid valve that I'm not able to repair, then we have to think about replacement, right? If there is any option for a durable repair, I'm still favoring the durable repair because nothing is best than using the native tissue from the patient, right? So if a valve cannot be repaired, then you enter into the world and the different options in terms of valve replacement. So the potential for growth is really something that is, very, very specific to this option, right? And the fact that they do not need reoperation down the road, right? And then once we select a potential candidate for an aortic partial heart transplant or a pulmonary partial heart transplant or a mitral pulmonary partial heart transplant, then we do. First of all, we work as a group, right? So the surgical team and the cardiology team work together. We see the patients together to give them some information about both the surgery and also the postoperative care and the immunosuppression therapy, right? And we also do some tests. We do some DSA, donor-specific antibodies, and PRA, panel reactive antibodies as well, to get a sense of the potential risk for potential rejection of the valve, right? And then based on that, sometimes if the DSA or if the PRA are way too high, we say that maybe there is a higher risk of rejection for your specific baby. So maybe we should consider actually another option, right, which would be more beneficial for your baby.
you mentioned DSA and PRA, which are, commonly also used in allogeneic transplantation and whole organ, heart transplantation. Is there ever a concern that doing a partial heart transplantation might sensitize the patient to a future whole heart or a whole organ
Yeah,
transplantation?
that's a great question. Yes, potentially, but also, that would be the case with a cryopreserved homograft as well. The literature and paper that are from 30 to 40 years ago actually showed the development of the both DSA and PRA after implantation of a cryopreserved homograft. Right, and so that's very interesting because these cryopreserved homograft and some of them actually were deteriorized and they still lead to the formation of some PRA and some DSA. Okay, but so that's a potential thing to keep in mind. But even if you do not implant a homograft, or even if you do not implant, a specific biomaterial, these patients after a first surgery, by exposure to the blood that we have to use for a cardiopulmonary bypass and other things, right? Actually, some of them do develop DSA and PRA. And finally, we do actual full orthotopic heart transplantation, even in patients which are highly sensitized, right? It's not a contraindication to a heart transplant anymore. Right. So this should probably not prevent us to go through a partial heart transplantation, even if later maybe this patient would need a full heart transplantation.
That's very interesting to know that it does not preclude,
Yeah.
future whole heart transplantation. Uh, from a surgical standpoint, because it is such an innovative technique, you mentioned that only about 5 centers are doing it at the moment. Could you tell us what is the most technically challenging aspect of this surgery?
Yes, absolutely. So, technically speaking, it doesn't change much compared to what we do, for example, for Ross operation, right? So for Ross operation, you get the pulmonary autograft of the patient and then you put it into the aortic position. So this is what we call an aortic root replacement. Actually, it's not only a valve replacement, it's a root replacement because you implant the whole root, right? So you also have to detach the coronary arteries and then re-implant the coronary arteries into the new route, right? So technically speaking, there is not much different compared to a Ross operation, right? The only thing actually is that, the harvest of the, let's say, aortic valve or the aortic root or the pulmonary root or the mitral valve on the donor heart is something that we are not used to do, right? Because when you get a cryopreserved homograft from a company, this harvest of the valve has been already done, at the company by people who are doing that, right? But here, when we get a heart, right, the surgeon on the table has to actually harvest the aortic valve or the pulmonary valve or the mitral valve, right? So we do harvest of the pulmonary valve in a routine fashion when we do the Ross operation, but many of the surgeons were not trained to actually harvest an aortic valve or harvest a mitral valve. But that's something that definitely is amenable to learning.
That's very interesting. So I guess now my question would be a little bit broader. So, as a person who wants to be in similar shoes as you, what would be your recommendations to, say, for example, surgeons who want to expand this technique into, their hospital? What kind of training do you recommend for
Yes,
those kind of surgeons,
yes.
and how do they expand it?
Yeah, yeah. So that's good. So what I would recommend. So again, from a technical standpoint, there is not much to learn. I would say it's more like I would say the logistics, right, and the multidisciplinary approach of it, right? Because as you can imagine, it really takes a village to get a partial heart transplantation program, get up and running within an institution. You need to have the buy-in, and you need to have the help and the expertise from cardiologists, from imaging, from heart failure attendings, right? As well. And also, depending on the origin of the valve, you may also have to work on the logistic of, for example, getting a valve from a donor, right, within your hospital. So this is what we did, as a domino, a partial heart transplantation. So the concept of a domino partial heart transplantation is based on the fact that the valve that we implant, the living valve, doesn't come from someone who passed away and donated the organ, right? But the valve comes from a heart that was explanted at the time of a heart transplant. So patient A has a cardiomyopathy, let's say, right? We do a heart transplant, right? So we get a heart coming from a donor, which will help patient A who needs a heart. Then we explant the heart from patient A, and instead of wasting this heart, we take the valve and we use this valve for a partial heart transplantation in patient B. Okay, so that's the concept of a domino. Okay, so you can imagine that if you're doing in your institution heart transplantation in patient A, right, and that you want to use his or her valve to help another patient, it takes a lot of coordination, right, and a lot of preparation between the family of the donor of the heart, and then the family of the donor of the valve, and then the recipient of the valve, right? So from a logistical standpoint, from also a legal standpoint, right, and an ethical standpoint, a lot of work needs to be in place to make this happen. So to go back to your question about what I will recommend, I will really recommend a team approach, right? Big time, right? That's not something that a surgeon or a surgical team can do by itself, right? That's really a team, a full team, including also legal and administration and all these people, right, who need to be on board and to help with the whole process.
That's amazing.
Speaking of all those hoops that you're mentioning that to make something like this happen, what are some of the key variables that are driving the need for such a complex logistical consortium of different parties working together? And then how could partial heart transplantation and or some of the projects that you've been working on in terms of storage of these partial heart transplantation address those issues?
Yeah. So what are the issues right now? What are the barriers, I would say, to a very wide clinical adoption, right? I would say that first of all, that's the availability of the tissue itself, right? It's not like it's still a human tissue, right? So the availability is not like endless, right? So that's the first thing. The second thing is once you have a tissue available, right? How do you allocate these tissues? Okay, because you can think about about it at the level of your institution. You can think about that at the level of your city or your state or nationwide. So, what the best way to do a fair and equitable allocation of this scarce tissue, right? So that's another barrier. The third barrier is about the viability of the tissue ex vivo, right? Once this valve is explanted from someone who passed away or a living donor, right? How long can this valve be stored ex vivo before reimplantation? And you can imagine that this will have a true impact on the whole allocation system, obviously, right? If you have to act quickly, and reimplant this valve in the first 24 hours, you don't have a lot of possibilities in terms of allocation, right? And I'm sure that we'll talk about that later, if we have a system in place or a technology in place that allows for an expanded period of time of storage, and even potentially a preservation or rehabilitation of this valve, then this would be a game changer because you can end up with a living biobank, right? a living bank of bank of living valves, basically, right, that become an off-the-shelf option, right, for patients, right? So I mentioned three barriers, and maybe I will end with the fourth one, which is, the risk of immunological rejection, right? So that's another important point to work on, and that our community should work on extensively to really understand what the exact type of immunological response, right? Do we need immunosuppression or not? If yes, what kind of immunosuppression and for how long, right? So answering these four questions or these four needs will really help with a wider clinical adoption of this technique.
Dr. Kalfa, you mentioned transplantation. One simple question that I actually have is which valves can be taken? Is it possible to take all the pulmonary, aortic, and the mitral if available?
Yes, absolutely. So we did actually some split partial heart transplantation, right? Which means that from a same donor, you can split the different valves, right? And help multiple patients, right? So that's a split partial heart transplantation. Technically speaking, when you do, so you know that because you're a surgical resident, right? But people may know that there is, what we call the mitral aortic continuity or the aortomitral curtain, right? So there is a continuity between the aortic valve and the mitral valve. So you can imagine that it can be difficult to get a nice both aortic valve and a pulmonary valve for two different patients, right? So there could be some anatomical, consideration there, but otherwise you can definitely get an aortic valve, a pulmonary valve, and actually many of our patients got two valves, right, from the same donor. Truncus arteriosus patients who do not have a pulmonary valve and who also have a leaking aortic or truncal valve, got both the aortic valve and the pulmonary valve coming from the same donor. Right. And we are currently working on different options for the mitral valve and the tricuspid valve as well.
That's very interesting. One of the previous things that you did mention was regarding immunosuppression. I'm sure that is a major consideration for, a lot of parents, especially this is potentially something that they have to take lifelong. Is there a possibility that not just reducing immunosuppression, but also eliminating immunosuppression might be possible?
Yes, absolutely. I think that this is possible, and I think that we will be successful in actually just not using immunosuppression. Why? So first of all, there is some potential concept in the literature in favor of an immune privilege, right, of the valves. Personally, I'm not convinced about it, right? Because we know and that we have shown both in humans, in patients, and also in animal models that there is definitely an immunological response to a valve that have been transplanted, right? But still, it seems like the immunological response to valvar leaflet is less compared to some endocardium and myocardium. Okay? The first part of the answer. The second part is about what we can do to actually decrease the immunogenicity of these valves or just get rid of them. So we have different works in progress on this topic. So there is a group also working in Eindhoven, who is working on shielding these valves, right? Using different techniques. There are also other tissue engineering options here, and there are also some options that we are currently working on in terms of exposing the valve to some specific biological cues, basically, to decrease the immunogenicity of the valve. So that's a work in progress, and I think that our field will be successful at some point in doing that.
Yeah, I think I agree that the future of this work is very exciting, and let me just backtrack a little bit. Although I'm not a surgeon, I can confirm that resecting the aortic valve and mitral valve from a mouse is very difficult. It's either one or the other, usually, in
Exactly.
my experience. Um, but you mentioned already the potential of partial hand transplantation to kind of infiltrate the tissue engineering heart valve space. Um, how do they compare from a extracellular matrix remodeling point of view between a tissue engineered heart valve, for example, and a valve that is stored for an amount of time? What are the concerns in terms of ECM remodeling and therefore valve function that may arise from these storage or rehabilitation conditions that you're speaking of?
Yeah, that's a tough question, Daniel. Um, so there are different things to consider here. So first of all, what's the impact of this cold ischemic time on the valve physiology, and at the end of the day, what the impact on the extracellular matrix, right? That's the first question. The second question is, if we try to store this valve, then what would be the impact of the storage conditions, which are biological, biochemical, biomechanical factors, and what the impact of all these factors on the extracellular matrix? So, we are working in the lab on a project where we try to store this valve, and we are now at a 7 weeks period where we can store this valve, but we have seen some a limited amount of retraction sometimes of this valve, right? So is that related to some impact to the extracellular matrix? Absolutely, maybe it does, right? So the field has learned a lot about that through, tissue engineering, as you mentioned. And I think that actually the two fields are very close to each other, and they will, feed each other in terms of knowledge, right? But the question and the true understanding about of the fate of this extracellular matrix is really, really, really interesting and very important for the patient down the road. And obviously, the fate of the extracellular matrix is very closely related to the fate of the cells, their viability, and their phenotypes, right?
Agreed.
So the VICs, the valvular interstitial cells, their viability and their phenotypes will have a direct impact, as we all know, on the extracellular matrix, right? So it's a pretty complex kind of dialogue between all these components, right? So a lot of work still needs to be done to really elucidate all these mechanisms and to try to understand what is best for the valve and at the end of the day for the patient that we treat.
Yeah, I completely agree. And I guess more here comes a more philosophical question. Um, in in your mind, what would be a more important successful criteria of the stored valves as from a functional point of view? Is it primarily the viability? Is it primarily the ECM composition? Or is it primarily the valve function itself? Like, could you have a perfectly well functioning valve tested, implanted in a patient which may not have the exact ECM composition, but the valves are alive? Like, what's your take on that? Like,
Yeah.
what would success mean to you in particular? Is it just recapitulating the in vivo baseline condition, or is there something else that drives that?
Success for me is a patient who keeps this valve functioning well for 60 years. Okay, this is what I would define as success. And so, how to get there? My gut feeling is that we need to maintain a normal physiology of the valve and maintain a normal extracellular matrix and living cells. Okay, so that's a way to get to the clinical success, right? And that's a combination of all what you mentioned, basically, right? That would be a combination of all of that.
Yeah, completely agree. Completely agree. That was an easy one. Um, and then I guess now we can jump on to, from a regulatory standpoint, this partial heart transplantation lives in a weird limbo
Mm.
area where it's not a full organ transplant, it's not a uh human cell tissue, or maybe it is. The FDA says it is. Um, how does that affect your surgical planning in terms of how you treat these partial heart transplants now? And then in the near future, the implementation of this storage and rehabilitation of the tissues, how is that going to change the FDA's viewpoint of partial heart transplantation, and what is necessary to overcome those barriers?
Yeah, tough question again. So currently, it's regulated by the FDA, okay, as a tissue. We had long discussion with the FDA. We had long discussion with the UNOS as well, and basically, UNOS considered that it was not an organ, right? So that was regulated by the FDA, and we have been in touch with the FDA. And so the program that are currently doing that are either accredited by the FDA, right, or approved by the FDA to do that, or they are working with other parties, basically, who are accredited by the FDA. Okay. In the future, since you are mentioning, our work on the bioreactor that we have been developing for the storage and the preservation of these valves. We will need, and we plan to have a discussion with the FDA about that, right? A discussion with the FDA, not only to prepare for the preclinical animal experimentation, and also at the end of the day, the clinical trial that we'll be doing, but also purely from a regulatory standpoint, right? How this would actually change, the model, right? The thinking about the regulation of this tissue, right? Because you could consider that doing this kind of storage and preservation is adding a process to the valve, right? So you could even now go into the concept of a medical device, right? Because you have this new process which has been added, right, to the tissue, right? But it's really, really borderline because even if you actually add a process, still the tissue by definition remains alive, right? Which is not the case for a cryopreserved homograft, which is considered as a medical device. So you are really here in a gray zone, right? From a biological standpoint, from a regulatory standpoint. So that's very interesting. That's fascinating to me. That's really a new era.
Yeah, definitely. I think I mean, one of the parts that kind of plague the congenital heart defect treatment options is the fact that, the big players in the valve field are not making bioprosthetic valves or mechanical valves that are small enough for children. Whether that's because of technical issues or financial issues, is to be determined, right? I'm not there to speak on that. But then, do you think that a large biobank would would take on something like this, where if it does need to be regulated as the FDA as a tissue that has been manipulated, do you think they would be likely to take this on and be able to provide these tissues for partial heart transplantations?
You mean industry?
Right. Or do you think this would be done only within the clinical and academic space, or do you think that the industry would have to kind of pick some of that up, or?
Yes, at some point, and we are in discussion with different companies who have expressed some interest, in this technology. And at some point, yes, I think that, a very close collaboration with industry and industrial partner to scale this up, right, will be the way to go. And there is a very strong interest, from the industrial community about it. Yeah.
Perfect. And then I have one last question, and then I'll hand it over to Ishit because he looks eager to ask you another question. Um, do you think partial heart transplantation could also be a therapeutic treatment eventually for acquired valvular pathologies in adults? Maybe even patients with bicuspid aortic valves who present with symptoms 2 decades before um, tricuspid patients and then require multiple surgeries throughout their lifetime. Do you think something like this would be potential solution for them as well?
Absolutely. And actually, we already did some partial heart transplantation in adults as well. And why? Because, the valve that we were mentioning in the very beginning, right? The valve that we would be using in adult, like a cow valve or a porcine valve, again, they degenerate. So, we were talking mainly about children so far in terms of growth, right? But in terms of durability, that's also the ideal option, right? Ideal option both for children and adults who still do not have the ideal way to replace a valve, even in adults, right? Because this tissue valve lasts for 12 to 15 years for the first one. And then if we do a transcatheter valve deployment, within a surgical valve, the transcatheter valve would last something like maybe for 8 to 10 years at most, right? So these are not durable options. So a partial heart transplant can actually bring the most durable option for the adult population as well.
Thank you so much, Dr. Kalfa. My question would be more forward-looking, and because you've been in this field for so long, you're doing some very innovative things. Uh, what, according to you, if you had to give me like a top three, what are the top three things, looking prospectively in terms of research that really excite you in this field at the moment?
Okay, so I would say that the development of this technology to store the valve and to preserve the valve is something very, very important for the patients. The second aspect of things is to induce some tolerance of this valve, right, and to decrease the immunogenicity of this valve. And finally, I would focus on the option of xenotransplantation potentially, for this valve as well. As we know that, human valves cannot be available for everyone, right? So if there is a way to, translate the concept of xenotransplantation for the partial heart transplantation and not for, the whole heart would be something also potentially disruptive for the patients.
That's
Awesome.
amazing.
Yeah, that's awesome. Before we wrap it up, Dr. Kalfa, I wanted to give you the opportunity to share any message you might have with our audience.
In terms of what?
Anything you wanna reach out to and say to the people within
To
the
the
Heart Valve
people of the
Society?
Heart Valve Society, what would I
Yeah.
say? You're doing a great job because Heart Valve Society is a very special society, right? It's, I think, the only truly multidisciplinary and interdisciplinary society, and that really, really promotes the discussion between physicians, surgeons, engineers, polymer science people, heart valve biology people. So, the work done and by the Heart Valve Society and through the Heart Valve Society is really absolutely, key for the development of new technologies.
Yep, couldn't agree more. Thank you so much for those kind words. With that, I think that's it. Again, thank you for joining us in this installment of the Heart Valve Society interview series. We hope you found the discussion as engaging, as informative as we did. Stay tuned for more interviews in the series, and we look forward to connecting with you again soon. Until next time.
Thank you. Bye bye.